And welcome everybody to Wound Care Gurus. Yes, it is your host, Bill Richland, and I apologize right up front that these wonderful winter changes have affected my voice tonight. So fortunately, I have brought on a really strong interviewee tonight who's going to carry the show for us because of my weakened voice. But we will make this happen, and we're going to have a great time. We've got a great topic tonight for you folks. I hope that you are going to enjoy what Katie has to share tonight. But before we get into that, I just want to cover some some background stuff, just a heads up. We got our upcoming Sharp Debridement class for 2022. So if you haven't checked out the website, sharpdebridement.com, these are our current locations that are up. We got Fort Lauderdale, Houston, Philly, Milwaukee, and Columbus. There's always a possibility we may add some classes depending on how things go. So I just want to give you the heads up on the up and coming Sharps classes. Please feel free to share this with your colleagues that would like to get Sharp Debridement training, because it really is an incredible course to get people a good solid foundation in wound care, but also to get them doing a much more advanced technique to help us heal our wounds, which is getting them debrided. On top of that, most of you have probably heard about our clinical support hotline. We launched this back in October. It is 24/7 access. You've got clinical support from all the experts on our advisory board. If you have not checked out our advisory board, I would highly encourage you go to woundcaregurus.com and check that out. We have an incredible board, including Katie, who will be interviewing tonight, is actually one of our board members. There's a great resource library. We've got a number of resources already up, and we're going to be adding more and more resources available to our paid subscribing members. We got training videos, and those will be continuing to grow in number as well too. We're working on putting up some clinical blogs on the members only section as well. It's $19.95 for an individual. We do have group and business rates for bigger facilities that want to buy packages for a number of their staff clinicians. But also, if you have not been to Wound Care Gurus, our website and or our Facebook page, there is a lot of free resources as well too. It's not all pay. So we have some great information, and we're always going to be turning out more information like tonight to help our clinicians out there better heal their patients. And then the last thing I want to bring up before we get in and bring Katie on is, how many of you have heard of Nancy Morgan's Wounds on Water National Conference Cruise? This is going to be absolutely incredible. It is set for May 20th or 16th through the 20th of this next year. This is going to be an incredible. We have a great lineup. A number of our Wound Care Guru advisory board members are going to be speaking at this conference. So it is going to be top-notch content, as well as just top-notch people that you want to be around in the wound care world, that are making things happen, that are truly living, breathing, and practicing evidence-based care, which is, you all hear us preach here at Wound Care Gurus. There's such a lack of real solid evidence-based care in the wound care world, and we're trying to change that. And that's kind of our main mission here at Wound Care Gurus, is really putting the evidence behind the care that we are recommending to our patients and our fellow clinicians. So with that being said, I want to bring on our interviewee for tonight. Hopefully everything works out as I planned. Katie, welcome this evening. It's Katie Ferguson. I want to welcome everybody. This is Katie Ferguson. I've come to know her over the last few years in our interactions at conferences and just talking on other airwaves out there. She has an amazing background as a therapist. She's got literally, every time I type in her her signature and her name. She's got like alphabet soup after her name. I'm not sure what certification she doesn't carry at this point. She is certainly well overwhelmed me, and I just can't keep up at my age, and I'm not going to try. But no, really, but the thing is, she walks the walk as she talks the talk. So, and I really think she's got some great information to bring to you all tonight, and I hope that you guys enjoy our interview and what Katie has to share. Please feel free to ask questions at any point. This is for my audience. If something comes up, Katie has been willing and agreed to take questions on the fly from the listening audience. So anybody have any questions for Katie at any point during this interview, just type it into the comment box and we will make sure. So officially, welcome, Katie. Thank you for joining us tonight.
Thank you so much for having me. Greatly appreciate it.
Great. Awesome. And you've got a good, strong voice, so you're going to have to carry the night while I just kind of hang back and throw questions at you.
Perfect.
But I won't go easy on you. Don't get it wrong. And I just want to let you know that.
I figured.
Still going to hit you with some good, tough questions because we want to make this good for the audience, and that's really what it's all about. Is the audience and making sure they walk away after our interviews with with new content and new information they didn't have before they arrived. So before we get into our topic tonight, which is kind of maximizing the use of therapy in home care, in the area of wound care, how about if you give us a little background about yourself so the audience understands who Katie Ferguson is?
Okay. So very similar to Bill and Denise, I've been a physical therapist for about 11 or 12 years. And out of those 12 years, 7 of those years has been designated towards primarily dealing with a ton of wound management. My first real experience dealing with on deck, like on hands wounds, was when I was placed in a burn rotation. It was an adult and pediatric burn rotation based out of Salt Lake City, Utah. And it was just eye-opening. I learned so much there. I, as a physical therapist, learned more than I even thought. In the OR, they had the PTs, the OTs there, ranging the patients while under general anesthesia, which was fascinating to me because I never thought that would be allowed.
Yeah, no doubt.
Right. And then we were able to fabricate and fit a lot of the orthotics while they were under general anesthesia, so it would fit properly. It was just fascinating. Then my next couple clinicals weren't as exciting as the burn rotation. They were just kind of very designated towards straight physical therapy stuff.
Sure.
And then kind of when I got out into the workforce, I landed a job for a long-term care agency with a short-term rehab abutting it.
Mm-hmm.
And that's, I think, where I kind of educated some of the clinicians as what PTs can do, because they invited me to go to wound rounds. And I think I taught a lot of the clinicians there exactly what PT can do. So that was eye-opening for them.
Mm-hmm.
And then I found myself in home care, and that's where I am right now. And that's my baby. I just love it to pieces. Not even relating to wounds per se, but anybody who walks into a patient's house, you have to be ready for anything. You have to be ready for dogs. You have to be ready for the entire family. You have to be ready for changing a dressing on a floor, changing a dressing on a top bunk. Like, I kid you not, I had to change a dressing on a top bunk. So you just kind of have to be ready for anything that the home environment throws you. And that's, I think I love that most about home care.
Yeah, I had that. I had the similar opportunity. I spent about 10 years doing home care.
Okay.
I did about 10 years in the long-term care industry myself, and then about 10 years in home care. So it was definitely a whole different animal than the nursing home situation. But it was very enjoyable. I love the autonomy. But you got to be on your toes, because you never know what you're walking into when you walk through that door the first time.
You never know. As many wound consults as I do, I'm walking in there kind of with what I have. I don't have the supplies readily available. I just kind of have some stuff that I have. So we just kind of have to use our imagination until our proper supplies come in. So it just kind of makes you think outside the box a little bit.
I'm dating myself, but MacGyver comes to mind for those of you old enough
Yes,
to remember.
MacGyver.
The MacGyver of wound care. That's what home care really a lot of times ends up
Yeah.
being. So, well, let's kind of dive into some of the stuff we wanted to talk about tonight, Katie. One of the questions I had is how does your organization utilize your skill set in home care to care for the patients? As far as things like what kinds of treatments are you providing most often? Let's start with that.
Okay. My organization uses me mainly for consults because I'm one of the only wound specialists there. So it can be something as simple as another clinician calling me, emailing me, texting me with an image, and saying, "Hey, this patient has this going on. It's not healing. What can I do?" And if I can figure it out just by talking to them within a couple minutes, excellent. And they don't need me to go in per se. They just have to document that they spoke with me. Um, but sometimes I will have to go into the patient's homes and figure out what I think is the best plan of care versus what is currently being recommended. And once I figure out what I think is appropriate, I will call the doctor. And if the doc's in agreement, I will write the doctor's order for them, and then I'll order the appropriate supplies. But I had a patient maybe a couple months ago that I did a consult for, and the patient had a stage 3, I think it was right-sided greater throat pressure ulcer, and stage 3, and the patient was using hydrocortisone cream for 4 months. Hydrocortisone cream on a stage 3. Why not?
That sounds like a legitimate evidence-based treatment I've read about.
Yeah. So I was like, ah. So those are some of my consults where they're kind of really easy. Other ones they've kind of like made me think.
Sure.
But minus consults, they'll use me for a lot of debridement, whether it's conservative, sharp at bedside,
Mm-hmm.
silver nitrate, sometimes modality usage,
Okay.
things like that.
What
But
type of modalities are you probably using most commonly in the home care setting?
so because I'm the only physical therapist there that's interested in wounds, we don't do as many as I would like
Okay.
because I can't be there
Right.
7 days a week. But the main ones that I would love to use are e-stim, ultrasound, shortwave diathermy, not really in the home setting, but they have that a
Mm.
lot in the long-term care setting. But things very similar to that. Pulse lavage.
Okay.
Dr. James Steele can tell you everything imaginable about pulse lavage.
We know Dr.
He
Steele.
knows.
We've interviewed him before, so pulse
Yes.
lavage. It's a great modality,
Awesome.
and I think it's becoming. I think the more studies and the more you have people like Dr. Steele or even Dr. Marasco, who has his own pulse irrigation system,
Mhm.
number of them out there, the more they get the word out about the benefits, it can change modern wound care. Everything doesn't
Absolutely.
have to be a scalpel all the time. And the stuff that I've really liked about what Dr. Steele's been doing recently in a lot of his studies, and we're hoping to get him to present some more of that after the first of the year, is using antimicrobial solutions to actually irrigate with.
Yes.
On top of just using saline, why don't we hit
Right.
it with something that kills crap at the same time?
Right. Why not?
So it'll be interesting to see what kind of results he's getting. But besides that, so interesting on the modality standpoint, what would you find currently in your experience of those modalities are you finding are the most efficient to use and the most that you're seeing the best outcomes currently with limited use, obviously, because you said you're the only one.
Right. By far, e-stim.
Okay,
Um, without a doubt. The science behind e-stim is just fascinating. I won't bore you guys with all the science behind it, but
that's
it
okay.
really is, it's a fascinating concept. And there was actually a study in 2014 performed by, I cannot remember the names of the authors, so I do apologize.
Don't worry.
But what they looked at was the benefits of e-stim, and they looked at the different parameters of e-stim, like whether or not it was direct current, alternating current, HVPC, which stands for high volt pulse current. And the conclusion was just basically use e-stim. It doesn't really matter the parameter, but as long as you're getting e-stim on these wounds, you're going to have a vast difference. So a vast improvement. And I love that article because it like it says, it showed you just
Mhm.
use the modality and you're going to have great outcomes.
Did
So I
you
think
have you seen any? thing in the literature that leans more heavily towards a more specific form of e-stim being the most effective if you had a choice. I'm just
What
kidding.
I
I've always been an HVPC guy. That's
Yeah.
most of the stuff I've read on. I don't
Yes.
claim to say that I am the authority on HVPC or e-stim in general. However, that has kind of been my, if I have a choice, I'm generally going to lean towards HVPC just because I've seen it to have some of the strongest evidence. But I know that there's evidence on other versions and forms of electrical stimulation wavelengths and stuff like that. So I was just kind of curious in your opinion,
I
if you've
also am
read
a huge fan
anything.
of the HVPC.
Okay.
I think because I've seen the most results from it, and then
Hmm.
you have the option of the like the monopolar versus the like the bipolar. So depending on the wound, depending on its appearance, depending on whether or not it's infection, then you can kind of choose whether or not you want monopolar, bipolar, how
Yeah.
far you separate the electrodes, things
Sure.
like that. So there's so many different options you can use
Right.
with eStim.
Hmm.
I love eStim for wounds.
That's awesome. Awesome. So I'm going to regress a little bit here and kind of step back we'll take a step back in time a little bit. Were there any challenges initially, or even say still ongoing, regarding making better use of therapy with regards to wound care patients in the home setting right now that you're seeing?
Yeah, we kind of touched upon a little bit about it a couple minutes ago, but the lack of therapists involved in wound care. Um, like we said, like eStim really should be used 7 days a week or daily, and if you don't have a therapist that's readily available 7 days a week, it's hard. Yes, we can get the patient their own eStim unit,
Good to hear.
but right, is it really as beneficial as like the big puppy that we're going to bring into the patient's room
Oh, sure.
versus the
Right.
little right? So that's a huge challenge, I think that we have, and also other clinicians realizing that PTs, OT speech can be involved in wound care. Um,
Mm,
Initially, I thought it was like kind of frustrating because they weren't informed, but now I just take it upon myself and I tell them, "Hey, this is what you can do. This is what you can do." So that's also a huge challenge. They're not they're not really informed when they're coming out of school or um, things like that. They're just not
mhm.
informed what therapy can do.
Right.
So they're kind of taken back. Like I get it all the time. They're like, "Oh, you're a PT? I thought you were a wound specialist." I'm like,
Yeah.
"I am. I'm both." Like I get
Still get
all
it.
I
Been doing
answer
this
my phone.
25 plus years, still getting the question.
Yep. I answer my phone like, "Hi, it's Katie from therapy," and then people hang up. And then they'll call me back. They're like, "Oh, I'm looking for the wound specialist." I'm like, "Oh, I am." They're like, "But," they're like, "I just called you." I'm like, "Forget it. Forget
Yeah, I get it. Yeah, there again,
it."
as I think we've talked about, there's a in wound care in general, there's a definitive lack of knowledge and
Yeah.
education. It's not people are stupid; it's that they're
Right.
ignorant, and that comes from a poor foundational, or poor foundation of just basic education in wound
Right.
care from all the disciplines.
Right.
We tend to learn our discipline, but do we take the time to learn what the other disciplines' roles are as well too?
Right.
And I think you're doing a great job in your role, obviously, and we brought you on the team because we want to use your platform and your knowledge base through our webinars, through conferences, through Facebook Live events to really get therapists on board and get nursing on board with you understanding that there is a big role to use PT, OT, and speech
Yes.
as well too. As I always like to, and I don't mean to brag about it, but I remember our very first year in 2020 when we started doing these Facebook Live. In May was Speech Therapy Month, and my wife interviewed one of her colleagues who's a speech therapist on speech therapy's role in wound care. That was the title. I think it was that simple. And literally within 7 days, we'd had over 1,000 views of that video.
That's awesome.
And I'm
That's
just
awesome.
like, and who would thought that people would care about speech therapy and
I
wound
know.
care, you
I
know?
know.
And I'm just like, then, but it just meant that there was this people going, what speech therapy, wound care? How can they, where's their spot in this? They were hungry to learn.
Right.
And that's really what we want to do is get that out there. So let's move
Well,
on
I
to
believe you have
another.
a slide.
Go
Don't you have
ahead.
a slide about
Yeah, I
was there a
do.
quote?
Yeah. Hang on, let me just make sure my mouse is clicking here so I can pull it up for you. I believe this is the one you were referring to.
Yes. So it's a team is not a bunch of people with job titles, but it's a congregation of individuals, each of whom who has a role that is understood by other team members. I think that's the huge take home message, that it's understood
Yeah,
by other team members. Yes, we know that speech is involved, but what is their role? I think
sure.
if you understand that, then you can have a greater appreciation for all the disciplines.
Exactly. Again, and like I said, I think you made that point. You got to understand what the role is. Anybody
Right,
can say, "Oh, I heard speech therapy does wound care, OT is involved," but could you explain what they do? You
right.
know, can you actually explain in a moderately intellectual manner what exactly OT does in wound care, or what does a PT do in wound care?
Right.
And I don't think a lot of people could if you put them on the spot to really say, hey, so what would you say a PT specifically? What do they do in wound care for you? And a lot of
Right.
people would be kind of scrambling to
Right.
throw together coherent sentences. And
Right.
nothing against them. It's just that did they really take the time to really learn what their colleague can bring to
Well,
the
while we're on the topic, we can discuss what OT does. Sometimes just kind of a
Yeah.
couple
Why don't you
basic.
touch base on it real quick? Just kind of give some
Yeah,
overviews.
so they can help with feeding, with the actual like the motor of feeding themselves. They can help with toileting hygiene, which I think sometimes we kind of take for granted. If someone's not able to perform proper toileting hygiene, they might have maceration, which might result in MASD or pressure ulcers. So if
Hmm.
they can't properly perform hygiene, we're going to be involved with more wound care.
Right.
So speech helps with cog deficits, swallowing deficits, making sure that they're getting the adequate dietary recommendations that our RD will make. So it's a huge collaborative approach, and people just really need to make sure that they understand that
Cool.
it's not just one clinician.
Right. Exactly. I always hear any of my students who've ever been to any of my classes I've ever taught over the years will hear one of my favorite cliches or little philosophies, and that is teamwork makes the dream work.
It's true.
And
It's true.
if we work together as a team, there's nothing we can accomplish. And it's been, I know Nancy Morgan and Denise, they've been Nancy recently has been doing a lot of stuff with trying to get lymphedema and wound care to start to collaborate
Yes,
together because there's always been this disconnect. And I think that is really going to change wound care when you put
absolutely.
the two together and realize they're not necessarily separate entities. They are very closely tied together in the wound care industry. So, well, let me move on to another question. Um, are there any challenges that you run into in coordinating with nursing sometimes when it comes to treating your wound care patients
Um,
and therapy?
Not necessarily really with the nurse themselves, but a lot of times with scheduling, because still sometimes scheduling. They know I'm the wound specialist for the last 5 years, but they still don't understand that I can't go in there and address the wound, and nursing can't go in there and address the wound the same day. It's a duplication of services.
Right,
They'll sometimes just be like, "Oh, we'll just go and do it, and you just bill it under PT." But I'm like, if I'm still addressing the wound, I can't have a nurse go and do the exact same thing in the same day.
right, 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 right.
Things like that, like just more like not with the nurse per se, because I think within the last 5 years, I think they've had a lot better understanding about what PTs can do.
Mhm.
So some of them are taken back initially, like if they're a new grad and they're like, "Who the hell is Katie? Like, I thought she was a wound specialist." Like, you know what I mean? Every time I get it all day, every day.
Right.
So
So, with that in mind, then, Katie, along the lines of obviously coordinating care, how can therapy be used to either increase revenue or at least start saving a home care agency some money?
okay. So I'm not sure if the certain terms, the DRG, I don't think those are available, or I don't think that term is used anymore. The
No,
diagnostic related group.
correct.
So back in the day, those scores would improve, like in the acute care setting, in the hospital setting. And back in the day, it used to be called RUGS, the
Hmm.
Resource Utilization Group. Now it's the PDGM, I believe. Those scores.
Are you talking long-term care or home care?
Yes. Long term
Uh, I think
care.
long-term care is PDPM. PDGM is
PDP.
home care, if I remember.
Okay, excuse me. Yep. Okay, so those scores should increase with
Hmm.
that. And then by increasing revenue, just if you use the proper dressing, if you do that, it's gonna help a
Hmm.
ton. The longer the patient is on services, the the higher the overall cost of the agency.
Sure. Hmm.
Um, Sometimes people will be like, "How does therapy save money if you're ordering $200 worth of supplies where I just ordered $50 worth of supplies?" And I tell them, like, sometimes you have to spend a little bit more money initially to save money in the long run.
Right.
Like, in home care, the agency will get like one big lump sum of money,
Uh-huh.
no matter for med patients, and that's doesn't relate to the diagnosis. It doesn't relate if you have 30 visits or 2 visits. They're still getting paid the exact same amount of money.
Right. Hmm.
So from a billing standpoint, they don't want daily dressing changes.
Right.
If we can go in there and provide the right dressings, like managing their exi date, so you don't have to have a daily dressing change,
Right.
that's going to help increase the revenue there.
Hmm.
So, and then at the end of the day, if we have a patient who is happy with our care, they have a better quality of life. God forbid they develop another wound in the future, or
Hmm.
if they know somebody, or just regular nursing or therapy,
Right.
they're going to refer. They're going to refer back,
Right.
and then they can get money that way.
Yep. I know
So just
that.
overall quality of life.
Yep. I know that when I was doing home care for about a decade, one of my things that would always frustrate me, and I couldn't understand why the agency was not conceptually getting it, but they would send a nurse out to do the wound care, and the therapist would show up later to do their gait training, and their balance and stuff. And I'm
Yeah.
just like, okay, well, the only reason the nurse showed up in the first place, and nothing against the nurse, was just a change of dressing for that day. Well, why couldn't the therapist just change the dressing while they were already there and not had to send that nurse out there? She could have gone and saw a different patient.
Right.
And, just
Right.
little things like that's one less visit. That's not
Absolutely.
necessary. If it was a dressing change or whatever that specifically required that nurse to be there, different story. But if it's just a simple dressing change, a therapist can be taught how to change a dressing. It's not that
I
difficult,
agree.
and
I
they can
agree.
and they can incorporate it into that visit, and it's not going to affect any of the rules or the guidelines or the reimbursement.
Right.
But it's just very interesting. That would be one of those kind of just I don't this doesn't add up to me because I mean I've owned my own business, been in business for myself for 20 years, so I know how to run a business, and it's all about how do you become profitable. You got to keep your doors open, you got to pay your bills, and you can't just throw money out the door like it's going out of style. I always use an example too when I teach my students. When it comes to dressing changes, you made the point uh, um, about the cost of dressings. I blow people's mind when I can tell people, I says, I can show you how to save money using $15 dressing twice a week over a $3 dressing change you change every day. And when you do the actual math and they're done, they're like, wow, oh my goodness, it's almost double using the cheap daily dressing when you look at the overall cost in the
Right.
end. But nobody breaks it down into that. They look at sticker price, $3 dressing, $15 dressing. Oh yeah, that $3 one's cheaper. Go with that one.
Right. It happens all the time. And
So
I'm really fortunate. My manager, whenever I do a consult, it's rare that she'll ever say, "Hey, Katie, like watch out the price," because she knows with those proper dressings, they're going to be on services less. So I got
yep.
a super funny story. There was I can't remember the name of the dressing, but I believe it was like an $80 dressing, and my manager gave me approval. She's like, "You can get two." I said, "Okay, I got to do this." And in the home, I tripped over a patient's cat and I dropped the $80 dressing on the floor. And I had to call my manager and be like, sorry, we're down an $80 dressing, but I was just like,
It was
oh,
the
just the
dam's
fact that
cat fault. It's the dam's cat fault, not my
I did. That's what I said, but And the patient was like, just put it on. I won't tell your manager. I was like, never, not in a million years.
5 second
And I'm
rule.
like,
5 second rule.
no.
Too.
So yeah, I'd say those are basically the main challenges: is lack thereof therapists and the not the best dressing choices for the most part.
Mhm. We did have a comment came up, Suzanne. She's joined. She said, joining late. Was there any discussion about PT doing modalities? And yes,
Yes.
we did. We talked about doing mainly ultrasound and e-stim. She did mention in her list MIST and VAC. I don't know if you're seeing that at all in
What is
your
it called?
the MIST therapy, ultra MIST.
Oh, yes, I've heard of it. I have not. I have not used it myself.
Okay, and then the other, of course, is negative pressure. I don't know
Yes,
if you get involved with negative pressure in your agency with from a therapy standpoint or not.
we do, but it's based mainly off consult. Like if it's not working, or if the wound
Gotcha.
looks funny after the negative pressure is applied, they'll just kind of make sure I go in and make sure it's not the machine, and then I'll just say okay, or I'll show
Okay.
the patient or the clinician how to do a bridge or like a triple bridge or something similar to that.
Gotcha. Gotcha. So yes, Susan or Suzanne, we did touch on. Katie did address that. Modalities are very important, especially eSTEM is probably
Yes.
one of the most key pivotal ones that you can be using in the home care setting. But not to take away from when ultrasound is an option, negative pressure, anything along that line. So, and again, to our audience, if anybody has any, continued questions, again, feel free to throw them into the comment section here as we are moving along. So we were on the discussion of obviously saving money and or bringing in revenue. Now, unfortunately, I know that one of the challenges with bringing in revenue in home care is you're only getting so much per
Right.
60-day period of time. It's not like you can petition them to say, hey, how about a bump up this month? You know,
Right. That would be nice.
wouldn't that be nice? And
Yes.
I know you gave us $1,000 last month. How about 1,500? Can we negotiate?
Oh, that'd be nice.
So let me ask you this then, because I think this is kind of as we start to kind of bring things and wrap things up a little bit, and you and I talked about this obviously before we went online, and that is what would be some of the best advice, Katie, that you can offer our listeners that currently are not seeing therapy being effectively utilized in the home setting and bring therapy into a more active role. So, what are your takes on that? I know you've got a lot of
I would
experience and
say,
probably
um,
plenty to say.
yes, I have a lot. I have a lot to say about that. Just get any therapist that you know that you think would be great with wound care. Just get them involved. Let them know what they can do. A lot of therapists may or may not have received education in PT school. I know my curriculum, we had an entire integ course. It was an entire semester. Other clinicians that I know, they say it was like a 2 or 3 day course. So they're not really familiar or comfortable with wounds.
That's two
But
to
just get
three
a
days. That's 2 to 3 days more than I got when I went to PT school. Just a heads up.
see, I had an entire semester. It was awesome. But let people know too that therapists not only address like with wounds, but therapists we can assess for like we can do an ABI, like an ankle brachial index with a Doppler. We can test for like capillary refill times, venous fillings times, or rubro dependency. They're subjective tests, but they tell us a lot without having to send them to vascular.
Sure.
And depending on the test that we do, we can come to a conclusion of how much compression or not no compression at all.
Right.
And if the ABI is below like zero point 0.5,
Mhm.
usually we say no compression. Um, and just kind of when you see a physical therapist with a patient or an occupational therapist with a patient and we're just walking with them, like if you're in a long-term care unit, just realize that we're doing more than just like walking. We're doing a gait analysis
Mhm.
on these patients. We're checking to see if they have a proper gait pattern,
Right.
heel, like a heel strike or toe off.
Right.
They don't have any of that stuff and they're diabetic and they may have more plantar pressure on the first med.
Mhm.
And that's something that we're looking at. We're not just
Right.
kind of
We're not
dallying
just
with.
we're not just taking them for a stroll down the hallway.
Right. That's what people always think. People think that all the time. But no, there's so much more to gait training that we do, not even related to wounds, but just
Right.
PTs. There's so many things that we can try to correct somebody's gait. My husband, he's a PT as well, and
Oh,
I don't
cool.
know about you, Bill, and Denise, but like we'll be out and I'll see somebody walking, and I'm like, ooh, I'm like, I bet that's like his left meniscus if he's limping, and we just try to figure stuff out because we always
Guilty.
analyze.
Guilty.
Yes.
Or I don't know about you, but we'll be walking around and we'll be, traveling or whatever. I remember we walked into I forget where we were at on location, but we were getting some lunch and we walked into Subway and we look at each other, jab each other. Can you say lipodermatosclerosis?
See,
And you're just like, it just never goes away. It's
it
always
never
there.
goes. It never goes away.
But, again, getting back to some of the stuff from a therapy that we didn't even touch on, we talked about modalities. But another area, is dealing with venous and lymphedema disease and the role of therapy getting those calf pumps activated properly. Because as I tell my students, I don't care what kind of compression wrap you put on a leg. If there's no active muscle movement, that compression bandage isn't going to do much,
Right.
So,
And then another thing that PT, I don't think I discussed this before, but a lot of things that PTs do for wounds are, there are a lot of positioning experts. Like we have wheelchair experts. Like we have orthotists. Things we have to get everybody kind of involved.
right,
And
right.
if you have, yeah. So always, always, always try to get PT involved, whether or not they love wounds or not. But if
Sure.
they have a pressure ulcer, get a positioning expert and try to redistribute their glute pressure, so it's offloading their pressure ulcer.
Mhm. Yeah, it doesn't have to be actual treatment of the wound itself.
Right.
There are so many indirect things, I think, is what you're alluding to,
Absolutely.
that have to be addressed as well, too, that not everybody's an expert at positioning. And like I said, lymphedema is its own animal in and of itself and has nothing to do necessarily with direct treatment of the wound, but understanding conceptually how to manage the lymphatic system and how to treat it will make a huge impact on what you do when you treat the wound too. So
Absolutely.
excellent. Well, I guess at this point, I don't see any questions coming in at this point, but so I'd kind of like to just throw it back to you one more time, Katie, and give you an opportunity to wrap up, share any key last things you can think of that you'd really like the audience to take away from tonight.
Just kind of get the entire team involved. I know there's so many probably presentations on this, but PTOT speech, the dietitian, somebody as important, but people don't think of them as important as a home health aide. There was a patient that I had that had just wounds on bilateral lower extremities, and it was because of improper hygiene. And all I did was ask the patient if she would be willing to see a home health aide, and they came in and showered the patient 3 times a week. And lo and behold, within a month, with what I was doing and with what the home health aide was doing, she healed.
Mhm.
So don't ever take it on yourself. If you have questions about anything, just reach out to your entire team. Like always, always, always ask questions. I still ask people questions. I'll call a nurse about a certain med. I'm like, hey, does this affect this? So everybody's here, like wound care gurus. You can always reach out to any one of us
Yep.
by all means. But yeah, just get everybody involved and try to get more therapists involved.
And I will just throw in, folks, just a reminder, this young lady will be presenting at the Wounds on Water conference.
Yes.
And just another plug for that conference, as well as Katie, because hopefully you've enjoyed what she has shared with you tonight. And I know she's going to put on an incredible topic and presentation at that conference. So I would highly encourage you guys. You can go to Nancy Morgan Wound Care on Facebook. Wound Care Professional, I believe, is her Facebook group. You can find plenty of links out there to register for the conference. It is limited seating because it's on a cruise ship. So this is not one of these conferences where there's, room for 1,500 people. This is going to be a very close-knit group of wound care professionals that are going to be able to rub elbows with some of the top dogs in wound care. We're very excited. My wife and I are planning to be there. Katie, Nancy, a lot of the wound care gurus advisory board are going to be speakers there. The Dr. Millers, Dr. Steeles, and it's going to be an incredible opportunity. And like I said, but I really appreciate you taking the time tonight to be with us in the audience. And I'm assuming and know that they appreciate the information you shared. I definitely took away some things myself because I've always tried to be open and learning. There is no such, you're either busy being born or you're busy dying. There is no just kind of status quo. And in wound care, you're either getting better or you're just kind of getting worse, because if you don't use it, you're going to lose it. And the only way you stay on top of things is you got to go rub elbows with the people that know more than you do.
Absolutely.
And that's kind of really what this is all about. So, well, thank you so much again for your time this evening, Katie. I really appreciate it.
Thanks
It
for
was
having me.
great having you on, and I hope we'll have you on again, okay?
You will.
All right, you have a very happy new year. Thanks again. God bless you, and we'll talk again real soon.
You got it. Thanks, Bill. Thanks,
Yep.
everybody.
Yep, bye, Katie.
Bye-bye.
So with that, everybody, that concludes our interview with Katie Ferguson tonight. I hope you took away some great information from that. And we are just excited to be bringing you more and more information coming up in 2022. As our organization grows, we appreciate your support in any way. And again, sorry for the voice tonight. I apologize, did the best I could. Hopefully everything will be better in 2022. So with that being said, I'm going to wrap this bad boy up myself and tell you all, have a wonderful evening. God bless you.